The next case, next friend.
Good evening, sir.
How are you, boss? Good evening.
Yeah, I'm fine, sir. How are you?
Alhamdulillah. Okay. Yes, you requested post-cesarean pain and fever. Operation done 2 weeks ago.
Post-cesarean. Okay, I'm provided with CT sections, portovenous phase of a female patient who has post-cesarean section and is complaining of pain and fever. I am scrolling the images from first to last before I start giving my my comments. Uh,
Okay.
so, um, okay, so in this images, I can see that there is some amount of air foci which is noted within the vagina with heterogeneous contents, which is seen extending from the cervix, extending up to the uterine cavity. The uterine cavity also appears distended with
Good.
some fluid and heterogeneous contents and some air foci within. I'm trying to look if there are
Is it
any.
accepted to see air foci post-cesarean?
Yes, sir, because it is post-operative. I think
For how long?
for the first 1 week, I think, sir. I'm
Yes,
not.
yes. Okay. Good, good, good. Yes. Not accepted to see this amount of fluid or air after 2 weeks. Good.
Yes, yes. Then I am trying to look at the extrauterine to see if there is presence of any fluid collections or any giveaway of the uterus as such. Though I cannot see any such findings. Based on these findings of distension of the uterus with heterogeneous internal contents and few air foci, my diagnosis would be that of puerperal sepsis in a postpartum female who's complaining of fever. So I would like to inform the findings immediately to the consultant for drainage, followed by IV antibiotics for treatment of this patient.
Good, good. But don't forget in my routine practice, I will check lung window for any free air. I will check sagittal and coronal. Why? What is the importance of sagittal view in this patient? And by the
I can
way, puerperal sepsis is a clinical term. We can call it endometritis.
endometritis.
Yes,
Okay, sir.
endometritis is a radiological term.
Okay, sir. So in sagittal, we can see the communication if there is any communication between the uterus and the bladder or any fistulous
Good.
formation between the anterior or posterior structures like the rectum or the bladder. Most commonly post C-section, there can be a rent or a giveaway at the anterior uterine wall. A communication can form between the.
Another value will be seen on the next case. Just give me the mouse. Okay.
Yes, sir.
Very good. It's a case of endometritis. Commonly, yes, yes. I'll talk about dehiscence يعني, in a few seconds. Okay. Okay. What about this case? The same complaint. 2 weeks post-cesarean pain and fever.
Yes, sir. I'm presented with CT scans, portovenous phase images of a female patient who's having pain and fever post cesarean section. And I would like to scroll the images from the first to last before giving my comments. And as I was scrolling through the images, my main findings appear to be heterogeneous contents, which is noted within the uterine. No, yeah, some air foci with subtle heterogeneity, which is noted within the uterus, along with large amount of para-uterine collection, which is seen extending up to the anterior abdominal wall, along with involvement of the rectus muscle. Also, some peripherally enhancing collection is along with air foci and
Good.
some amount of subtle enhancement which is
Yes,
noted
yes.
in the.
Stop here. Stop here. Yes. Can you comment on the uterine wall on this area?
Yes, sir. There appears to be a giveaway of the uterine wall or this area with the
Good.
communication with
Good.
the endometrium. So the collection appears to be appearing tracking from the site of dehiscence. The collection
Excellent. Yes.
anteriorly into the anterior abdominal wall, involving the rectus muscles,
Good.
and also
In my routine practice, I will.
I would like to immediately, urgently involve the
No, no, no.
okay.
Before managing the case, comment on other planes on other. Okay. So in my
Yes,
routine practice, I'll check other planes to confirm this possibility. Yes,
yes.
we have a continuity through the defect at the scar and the periuterine collection. It's surrounding the uterus. It's not continuous with the peritoneal cavity, but actually it's around the uterus. In such case, what is your diagnosis?
This is uterine dehiscence of the
Excellent.
uterine. Yes, a scar occurs on or giveaway of the uterus along, and there is
Yes.
a migration or of the contents from the uterus into the anterior
Yes.
abdominal wall.
And this is an important value here, as one of our friends asked it. Okay. Retain the products of conception. Yes, Dr. Amiga, it's commonly retained the product of conception is the underlying cause of endometritis. It's common. But of course, ultrasound will be more sensitive. Here, unlike the previous case, we have some evidence of endometritis and the defect and abscess formation. Through this defect, abscess is formed and continuity. This is a uterine dehiscence with infection and abscess formation. It's not continuous with the peritoneal cavity to diagnose a uterine perforation, for example, and diffuse peritonitis associated abscess in the rectus as well. Very good, my friend. So the first case, just endometritis. The second case, endometritis and abscess and dehiscence. Very good, very good. Okay, one last case for you also.
Yes.
What do you see?
So I'm provided with the T2 axial MRI sections um, of the pelvis, wherein I can visualize
Post-cesarean also, post-cesarean, okay.
post-cesarean. Okay.
Pain
So
pain and يعني tenderness, but no fever.
pain and tenderness, but no fever. Okay. I can see a relatively well defined collection with internal heterogeneous contents noted anterior to the uterine wall. So I would like to visualize these findings on sagittal images or other sections.
Good. Other sequence. Good. But before I give you, because sagittal will be diagnostic, okay. Any possibility, any suspicion? What is this?
Um, Sir, because it is, sir, there one is because it is post-cesarean section, it can
Mm.
be a collection which is formed at the site of the section. So it can be a contained perforation at the site of uterus. Or a
You see,
second,
do you see any because you said contained perforation is adhescence. Do you see any defect, any continuity?
no, no, sir, not in this images.
Good, good, good. This is a value of the sagittal. Good. So, collection. Can you name this collection?
Yes, sir. It can be an endometrial deposit which can appear, especially occur in post cesarean section, sir, because of
You mean endometrioma? Scar
yes,
endometrioma?
yes, sir.
2 weeks after cesarean? Okay,
No.
okay. Thank you, my friend. I will continue with the next candidate. Thank you. I'll tell you now. I'll tell you. Okay, the next
Okay.
candidate.
Hello,
Well
sir.
done, my friend,
Assalamualaikum.
by the way. عليكم السلام ورحمة الله وبركاته. Can you ask for control?
Sure, sir. Thank you. Yes, sir.
Okay, I will give you sagittal, describe, and tell me the diagnosis.
So I've been provided with sagittal two images of the MRI pelvis of a post-cesarean section female, whereas you can see a well-defined Waldorf collection as was seen on the axial images. No surrounding fluid is appreciated. I can appreciate
And
that
no continuity with the endometrial cavity. This is important. No continuity with the endometrial cavity. correct?
Right, sir. Right, sir. I
Good.
cannot appreciate the visible continuity of this collection with the endometrial cavity. However, there is a horizontal T2 hypointense area that appears to lie within this, in between this collection and the endometrial cavity, traversing the anterior myometrium.
The scar site, which is close the
That's
scar site, not defective, not
erythematous tissue.
dehiscence. And this collection is exactly situated between and lower anterior uterine wall, which is a scar, and posterior superior bladder wall. This location is impressive for, what is your diagnosis? Post-cesarean collection between anterior uterine wall and posterior bladder wall is named,
bladder flap hematoma.
Yes, okay. Bladder flap hematoma. And if secondary infection occur, it's infected bladder flap
Bladder
hematoma.
flap hematoma.
If continuous with endometrial cavity, okay, so dehiscence with bladder flap hematoma. This is important and very common complication. Let's revise. What are the complications of cesarean section you are looking for? This is an important topic, my friends, also for practice, not just as exam. What are the complications for cesarean section?
The same endometritis, scar dehiscence.
Yes.
Retained products of conception.
Yes.
With superinfection.
And also bladder flap hematoma,
bladder
infected
flap
hematoma.
with superinfection.
Okay. Dehiscence and perforation. Okay. And any post-operative, like what? Gossypipoma, ovarian thrombosis. Okay. So we have acute complications and chronic complications. Usually the acute is more important in the exam setting and also in practice. Bladder flap hematoma or infected, uterine dehiscence or ruptured, iatrogenic rupture of the urinary bladder. We covered, I think, a similar case in the last session, and venous thrombosis, especially ovarian vein. Very good, my friend. Let's see the next case. Okay, recurrent abdominal pain and fever, as I remember. Let's see what happened.
I've been provided with post-contrast CT abdomen of a patient who has presented with recurrent abdominal pain and fever. The lung bases are included.
And bleeding. Okay.
Fever, abdominal pain, and bleeding.
Yes.
Right. So thank you so much. I'll take a moment to scroll through the images and then start presenting my finding. No obvious hepatic or splenic lesion could be seen. There was a sliver of fluid in the right hepatic space with few renal cysts. I could not appreciate in pleural effusion in the lung bases initially. Some artifacts are appreciated in the pelvic images, likely because of spinal fixation devices posteriorly.
Good.
I can appreciate a filling defect on the right side. I'm trying to locate its position. It's likely in the right gonadal and parauterine vein.
Excellent.
The parauterine vessels are congested and inflamed. There is a fat-containing left-sided groin hernia as well.
Good, my friend. Just show us abnormality again.
I'll go to the
also
area
has
where
some bleeding, okay?
Sir.
This is important case, my friends, and commonly missed in practice. Yes, go up. Because ovarian veins or gonadal veins formed of 2 or 3 trunks. You see here. It's 2 or 3 trunks joining each other. So take care about this point. Ovarian and gonadal, testicular, whatever, okay, formed of multiple trunks. On the right side, where it drains?
On the right side, it drains directly into the IVC, while on the left side, it drains into the left renal vein.
Can you show me the left side?
Sir, on the left side, it's this one.
Is it normal size?
it's engorged. It looks engorged.
Yes. And
The,
does it look like venous flow? It's very
no,
high. Maybe it looks
it's
like arterial
arterial,
due to reflux. Due to reflux. This is the cause of bleeding. And show me the uterus down.
sir.
Is these vessels normal
No,
or
the
engorged?
subserosal vessels are significantly enlarged and hyper-enhancing. So there's
Diagnosing what? Pelvic
uh,
congestion syndrome. This is the
pelvic
cause
congestion.
of bleeding and pain, recurrent pain and bleeding in absence of fever. This is a very common and commonly missed cause. In such condition, thank you, my friend. Okay, of course, we need thrombolytic therapy. I'll talk a little bit about this case also for practice, my friend, not just for the exam, but for practice. Okay.
Sir, thank
Ovarian
you.
veins lie anterior to the source. It's commonly يعني underdiagnosed or misdiagnosed pathologies. On this side, definitely it's hugely enlarged, and enlargement in any vein with a filling defect equals acute. So it's acute. And in such case, smudge of the fat planes because it's commonly thrombophlebitis, ovarian thrombophlebitis, not just ovarian thrombosis. A common complication in case of PID and in post-operative as well. It may complicate other conditions as appendicitis or diverticulitis or colitis. Okay, right side thrombosis more dangerous because it ends in the IVC. Left less significant, but left ovarian vein reflux is a common condition. What is the underlying pathology? Commonly anterior nutcracker because it joins the left renal. But here, no nutcracker, so it's native reflux. It's a primary reflux in the left ovarian vein. If reflux, it will be enlarged and easily seen, and a secondary symptoms or signs, engorgement of the pelvic vessels and uterine and parauterine. Another possible cause for pelvic congestion, we have to look at this area. If we see a compressed left common iliac vein, what is the name of this condition?
Yeah.
May
Sir, I've
Turner.
forgotten the name that compresses between the
May Turner syndrome. Okay, May Turner syndrome.
maternal.
Okay, so in pelvic congestion, either compression of the left common iliac, May Turner, or compression of the left renal vein, nutcracker, or native reflux of the left ovarian vein, as this case. Okay, this case mainly for practice, but this point for the exam. Okay, my friend, another case, and also, by the way, post-operative complication, ovarian thrombophlebitis.
Sir.
What about this is another case, acute abdominal pain, ultrasound normal or unremarkable, CT unremarkable, middle-aged female.
Thank you, sir. I've been provided with axial T1 images of a middle-aged female patient who has presented with acute abdominal pain and unremarkable CT and ultrasound till now. I'll scroll through the images to look at my findings and then will start presenting them. I could appreciate some heterogeneous signals anteriorly to the right rectus muscle that were invaginating into the overlying. Sorry?
Good. Any history you want to
Sorry.
ask about in this middle-aged female?
Yes, definitely. I'll ask about any previous history of known endometriosis or any previous scar, any cesarean.
Any cesarean, not endometriosis. Endometriosis is a diagnosis. Okay. Yes. Positive history and also type of pain, cyclic pain.
Cyclical.
Okay.
Right.
And we
Yeah.
confirm on other sequences as T2 fat cell. Very good. And also enhancement. It takes enhancement in some periods of the cycle. So this is a scar endometriosis. Okay.
Sir.
Okay. I think one last case. Okay. What do you see here?
grossly reduced signals of diffusely reduced signals of liver as compared to the splenic parenchyma with some lobulated margins. Pancreas and splenic parenchyma signals appear unremarkable.
I don't remember. I gave you this case maybe 2 sessions before. I don't remember. Acute pain in pregnant lady. This is an important indication for MRI. MRI in pregnancy. Acute abdomen. What you are looking for, the common causes of acute abdomen.
Any ovarian pathology that is caused during pregnancy, any red degeneration of the fibroids.
Okay, this is a gynecological related or obstetric related. Sometimes not
Yes.
related, like this case.
Right, sir.
The gastric pain.
There are some heterogeneous signals around the pancreatic body and
Yes.
tail.
Yes. And the fluid.
These are separately seen from the left kidney, adrenal, and spleen, and predominantly centered around the pancreatic parenchyma,
Good.
the lesser sac, and around the tail. The pancreatic head and unseen process appear unremarkable. The rest of the mesentery appears smudgy.
I'm sorry, pancreatic. Yes, the lower part is unremarkable, but definitely the head and body and tail heterogeneous, enlarged, surrounded by fluids, smudging fat planes, pertinent negatives.
The pancreatic duct is not dilated. I cannot appreciate any filling defects within the pancreatic duct or in the assessment of the gallbladder to suggest presence of stones. This can be acute pancreatitis with
and also pertinent negative, patent preserved signal void vessels. This is important.
Sir.
I want to rule out any thrombosis. No pseudoaneurysm, no rounded structure with signal void or swirling. Okay, and also very, very good point from you. No gallstones. What is the expected? Maybe related to pregnancy, maybe alcoholic. I don't know. Okay, so in this pregnant lady, it's a case of acute pancreatitis. Okay, thank you, my friend. Well done. Well done.
Thank you so much, sir.
Well done. Okay, I think the last candidate.
We finished, Doctor. If you would like to have one extra, that's fine.
We finished, mashallah. Okay.
We finished the 7, yes.
One extra. Good.
Okay. The backup, please. Number 8, proceed.
Okay, assalamu alaikum, sir.
Alaikum assalam wa rahmatullah wa barakatuh. Okay, another pregnant lady with acute abdomen. Can you ask for control?
Okay, sir, requested. Just trying to scroll, but
Take your time. Take your time. It takes a couple of seconds. Yes, you are the one controlling now.
okay. So this is axial T2 images of a pregnant lady who have been presented with pain.
Right-sided pain.
Okay, so I'm just going through the images before describing them. So here I can see that the liver appears unremarkable.
Yes.
And gallbladder is quite distended as patient has right pain. So I'm looking at the
mild back pressure changes, but usually symmetrical because pregnancy-induced hydronephrosis is a common cause of right-sided pain, as most of the uteri are dextrorotated in nature. So they compress the right ureter first. But here it looks symmetrical. Good. So gallbladder looks good. Right kidney accepted. No collection beneath or below the liver, as in case of perihepatitis or Fetzo-Cortez syndrome. Downwards, I will check the ovary, the right ovary, for any ovarian torsion, which may occur also. Any ovarian vein thrombophlebitis, smudging fat planes along the right psoas. Till now, nothing, but we have important structure.
Okay,
responsible
sir.
for right-sided pain, usually right iliac fossa, but in case of pregnancy, it will be right upper quadrants.
Okay,
what is this
so
structure, my friend?
I'm just going again
Any fluid in the right side of the abdomen?
Yeah, so
Any
I can see
fluid?
that there is a fluid in the right
Good.
paracolligator,
Good. Go
and
up.
also
Yes.
an ovary which is seen just adjacent to the
Any rounded structure with signal void focus inside. Do you see anything like this? Any rounded structure?
yeah,
Just below the inferior margin of the liver. Go down, go down, go down,
okay.
go
So
down.
yeah,
Use
there
your
is
pointer. Use your pointer.
this one.
No, no. To the right, to the right, to the right. Yes. Go up and down. You will see up and down. You see the filling defect?
Yeah, so
What is this structure?
I'm just trying to
Rounded structure on multiple successive planes. It means it's a tubular. Signal void inside. It means either air or appendicular.
Yeah.
So this is a case of appendicitis. Appendicitis in case of pregnancy usually acquire a higher location, not the usual location in the right iliac fossa. Here we have a fluid, a free fluid in these areas, some smudging fat planes. It guides us to the source of acute abdomen or infection, and we start below the liver downwards. Okay, you see the filling defect again? It's appendiculate, obstructing appendiculate. Very good, my friend. No abscess formation, just inflamed fat. And if this inflamed fat planes and fluid anterior to the psoas muscle, I have to look for ovarian vein thrombophlebitis. So again, in case of pregnant lady with acute abdomen, look for appendicitis in MRI, pancreatitis MRI, ovarian pathology, like what? Proceed through this case.
Okay.
Pregnant lady with acute pain. What do you see?
Yeah, and I can see that there is another structure. This is similar to the I'm just going through the images. Cannot scroll basically.
I will scroll for you. Okay, I will scroll for you from up downwards. Okay, this is a pregnant uterus.
Yeah, but I can see that there is an other structure which is just posterior to the gravid uterus, similar to the endometrium and.
This is the right ovary. Look here. This is the right ovary. You see, normal right ovary. Where is the left? I cannot see. This is the cervix, normal. But what is this structure seen in the posterior cul-de-sac? High signal and
fully arranged cystic structure, most likely follicles.
Excellent.
So, with central stroma, which is showing high intensity on.
Excellent again. Yes.
So this may be a torsed ovary due to
torsed left ovary. Torsed left ovary. This structure, high signal, stroma, means edema.
Yeah.
Peripheral located small cystic structure. It's follicles. What about this rounded structure inside? No problem. It's corpus luteum of pregnancy.
Yeah, corpus luteal.
Yes, corpus luteum of pregnancy. Corpus luteum, in case of pregnant lady, it continue growth till 3 months. So this is early or first trimester. So this case, ovarian torsion in case of with pregnancy. Okay, so MRI, acute abdomen in pregnant ladies, very, very important. The last case, a little bit difficult, but we will go through step by step. Actually, this patient is not acute, chronic pain and dyspareunia.
Okay.
But
so
it's
a
a common exam case. What do you see?
So I can see that there is a large, well circumscribed structure which is showing intermediate intensity on
sequence
T2.
First, T2 fat set. Good.
T2
So,
fat set, yeah.
intermediate signal intensity.
Intermediate intensity on T2. So I'm
My routine
looking at,
practice.
I will check the further sequences and reformats.
I'll give you first T1, also fat set. So it's not dermoid.
Yeah, so it's high on T1, so
High
it's
on
maybe
T1.
less
Less
an intermediate or shading on T2.
Yes,
So
excellent. T2 shading, plus or minus. Sometimes we may see a dark signal inside. It's called dark
yeah,
T2 focus or nodule.
yeah,
Both signs,
yeah,
dark T2 and shading, classic for
endometrioma.
excellent, my friend. What else? What is this?
There is an other very
This is the uterus, correct? This is the uterus. And this is the
yes,
cervix. The cervix is
yeah, so
situated within the vagina. Why I injected fluid or gel inside the vagina, and this is air. And
just to
why? Yes, you see,
for the presence of any communication between the
good, good.
and
This
here
is
I can
the
see
yes, this is the bladder, urine and bladder. It's a fluid, urine. But here's the
yeah,
vagina. I injected not usual fluid, not saline. It will go out. Usually gel. In order to
okay,
image this area, we injected gel. Okay, so this some air fluid, no problem. It يعني go with the injection, and also here some gel with fluid. So I
yeah,
needed to visualize the vagina and I needed to visualize the rectum. Why?
yeah. So here I can see that there is a mushroom-shaped structure which is present on
Excellent.
the
Excellent.
rectum, which is showing low T2 signals. So this is endometrial deposit, which is causing
Yes.
mass effect over the rectum.
Yes.
So this is deep
DIE.
endometriosis. Yeah,
Excellent. Deep infiltrative endometriosis, a mushroom appearance, a low signal intensity started here. You see, this is a posterior fornix. This is the cause of dyspareunia in this patient. It's common underdiagnosed case. You see, I need to inject fluid or gel inside the vagina and inside the rectum. It affects the anterior rectal wall, causing serrated appearance seen on contrast enema. And it is continuous along the posterior vaginal fornix. It's very important to mention this relation because if we do a laparoscope, it may end in fistulous formation. So
okay.
mapping is very important before any laparoscopy. Very good, my friend. I know this case is difficult on axial. It's difficult,
Yeah,
but why they injected fluid in the vagina? Look for fistula, look for DIE, a local cause. Okay.
yeah.
Thank you, my friend. Thank you
So much.
all. Okay. I hope يعني